him have the screen.
Go ahead and put this in slideshow view. All right, perfect. Thank you for that introduction. So today, I know a lot of times, especially in ID, we get bogged down in some of the more interesting cases that we don't see commonly. So I think a lot of times a nice refresher on the infections that you're going to see every single day come through your hospital, regardless of where you are, is very good and warranted. So that's what we'll be talking about today. Nice. Oh, we're that's it, guys. Thanks for coming. All righty. So for some objectives for today, I want to start off by outlining some of the available state-specific resources available from ASC-SC, specifically some of the ways you can access that through your mobile device. Then we'll move on to the meat of today's discussion by starting with the discussion of the epidemiology, microbiology, and treatment options for bacterial pneumonia, both community-acquired and hospital-acquired. And then we'll finish off with just a review of some of the South Carolina-specific guidelines regarding the treatment of urinary tract infections. So let's start by looking at some of those state-specific resources available to all of us here via ASC-SC. So I don't know how many of you guys have Sanford downloaded on your phone. I know I did before I learned of this, but something that's recently become available is actually our specific guidelines, which is available on the free version of the app as well. So you don't have to pay for the Sanford guide in order to get these. But I did just want to briefly show everybody how to access those because I think this is an awesome resource regardless of where you're practicing in South Carolina. So obviously this is, for me, I went through this process on my iPhone, so it may not translate one-to-one for non-Apple devices. I apologize for that. But obviously locating the app, this is what it'll look like when you log in, at which point you can access state-specific guidelines via the add-ons feature here. You see we're up here with some of the other states that share their content through Sanford. You just download those and then it'll show up on your home screen as such and you can access those. Just some of the content that's available, and I'll reference some of this, especially at the end of today's presentation. We have a statewide antibiogram, and we also have that broken down into regions as well. And this is accessed at your fingertips on your smart device. So I pulled an example of what one of those looks like on my phone. So it's very easy to see on your phone. This is actually a screenshot from my phone of what the statewide antibiogram looks like, just for your reference. And then also some of these South Carolina specific state guidelines. So if you click into this tab here, you can obviously see that we have guidelines for acute sinusitis, inpatient diabetic foot infection, inpatient UTI, and outpatient UTI, and outpatient acute bacterial skin and skin structure infections and bites. You click this PDF, they're very reader friendly, even on your mobile device. And some other resources that are available through this app include schedules for what we're doing today. So the inpatient teleecho meetings and also the outpatient teleecho meetings. You can see the recordings are posted there of previous meetings if you want to go back to refer to those. And there's also some links to some very good literature that's taken place here in South Carolina that you can kind of access. And it's kind of like a walkthrough time throughout the years of some of the good things that ECHO's been doing. So I wanted to point all that out. This is also available on the computer, but this being so easily accessed through the app is something I wanted to make available to everybody today. So now let's start talking about some of the diseases we're here to talk about today. We'll start with talking about the epidemiology, microbiology, and then we'll get to the treatment of bacterial pneumonia and some nuances associated with that. So let's talk a little bit about pneumonia. Why do we care about it? Mainly because it's extremely prevalent. So it's the 6th most common reason for inpatient visits in the United States. It accounts for about 226.8 per 100,000 hospital stays. And it's the second most common infectious cause for hospital admission behind sepsis, which just for trivia purposes, the #1 cause for sepsis is actually pulmonary infection. So they kind of go hand in hand in that regard. Risk factors for developing pneumonia and having complications secondary to pneumonia include extremes of age. So patients who are less than or equal to the age of 2 and greater than or equal to the age of 65. Certain occupational hazards, obviously, anyone who's going to be inhaling irritants, coal miners, et cetera. Smoking is a major avoidable risk factor for developing pneumonia. Drug abuse as well, as this can cause patients to be in an immunocompromised state. Structural lung disease such as COPD. Critical diseases that require hospitalization, so just being in the hospital, as we'll talk about, can predispose you to some of these pathogens that cause healthcare associated infections, and then immunosuppression as well. So I want to talk about community-acquired pneumonia first, and then we'll talk about some of our hospital-acquired ventilator-associated pneumonias. Historically, I know when I was in school, this is kind of how it was taught to me. The bugs we worry about obviously are strep pneumo. So that's our gram-positive organism that we focus on in community-acquired pneumonia, Haemophilus influenzae, Morex electrotaurus, and then some of our atypicals, so Legionella, Mycoplasma, and Chlamydophila. Recently, there's been a shift in some of these causative pathogens and how often they pop up in community-acquired pneumonia. So I pulled some data from a systematic review that was published in 2020, looking at exactly this, the microbiology behind bacterial community-acquired pneumonia. And you can see our major players mostly have stayed the same. So you see that the vast majority of infections are caused by either strep pneumo, which accounts for around 50%, Haemophilus, which accounts for about 10% of our community-acquired bacterial pneumonias. Our atypicals as a whole count for about 25% of our community-acquired bacterial pneumonias. But you see there at the bottom, something's a little different. Around 5% of the bacterial community-acquired pneumonias in this study were secondary to Staph aureus, which could represent a threat in coming years, as this is only 5% now, but this is something that's relatively new. And something to note about those 5% of patients are that most of the patients who are developing these community-acquired pneumonia secondary to Staph aureus are young, healthy patients. The manifestations for these Staph aureus species that are floating around in the community oftentimes lead to necrotizing pneumonias and very serious presentations. So that's just something to note. And then for the microbiology for HAPAVAP, it's not as well defined. It depends on the local prevalence, your local prevalence of these resistant organisms, but some of the common pathogens associated historically with hospital-acquired pneumonias include Staph aureus, Pseudomonas, and some of our other gram-negative enterics, such as Enterobacter species, Klebsiella pneumoniae, E. coli, Serratia, Proteospecies, and Acinetobacter species. So a common theme of this is a lot of these bugs are difficult to treat, have multiple mechanisms for resistance, which can make managing these patients quite complex and complicated. Just to refer to the treatment guidelines that are the most up-to-date guidelines that we have for the management of these infections. Our community-acquired pneumonia guidelines, which are IDSA endorsed, were published in 2019, which you see on the top here. Also co-authored by the American, or co-endorsed by the American Thoracic Society. And our VAP and HAP guidelines were published in 2016. Also, both of these are available for your read. They're both very reader-friendly. I'm sure most of you have already skimmed through them a few times, but you can always go to IDSA's website to access these in full, but I'll make reference to these throughout the remainder of the slides today. So I want to talk about kind of how we would work up a patient with CAP, and then we'll talk about some treatment and some considerations that I think aren't as well fleshed out in the guidelines as well, but let's start with workup. So for cultures, the CAP guidelines that were published in 2019 recommend sputum and blood cultures, and I'm mainly going to refer to the inpatient recommendations from those guidelines. So those guidelines draw a hard line between outpatient management of community-acquired pneumonia and inpatient management of community-acquired pneumonia. We'll focus on inpatient today. So for those inpatients with severe pneumonia, they recommend getting sputum and blood cultures, and all of the patients with severe CAP, which if you look at the image to the right here, there's some criteria. You can either meet one of the major criterion or 3 or more of those minor criteria, and I won't read them out to you. In order to be considered severe CAP, all of those patients should have cultures drawn. And any patient where you're empirically covering for Pseudomonas and or MRSA, you should also get sputum and blood cultures to help guide that therapy. Also, some antigens, some urine antigens that may be helpful in nailing down a causative pathogen in community-acquired pneumonia, or Legionella and pneumococcal antigens. These are recommended also in that severe community-acquired pneumonia group. And also, if you have a case that's associated with Legionella outbreaks, it's recommended specifically to get the Legionella urine antigen in order to kind of nail down that diagnosis. Very, very briefly, you can break down your treatment in the inpatient setting based on those severity factors. So if you have a patient who does not meet any of those severity factors, but does require inpatient management for their community-acquired pneumonia, you essentially have 3 options. And I'll talk about the pros and cons of each of these on a coming slide. But you have your combination therapy with an IV beta-lactam. Usually this is going to be ceftriaxone or Unison, plus a macrolide for that atypical coverage, mostly in the form of azithromycin, although the guidelines do also mention clarithromycin as an option. Another option is IV beta-lactam plus doxycycline, also getting that atypical coverage. And then you can use an anti-streptococcal fluoroquinolone monotherapy in these non-severe patients. And I chose that terminology very deliberately. A lot of times we call these our respiratory fluoroquinolones, but I think that's a misnomer in a way, as that oftentimes leads to Cipro not being used to manage any type of pneumonia. That's certainly not the case. It gets excellent lung penetration. It just for empiric cases doesn't have that streptococcal coverage that we would desire. Therefore, our anti-streptococcal fluoroquinolones such as moxifloxacin and levofloxacin kind of fit that bill, and that's why we use those empirically for the management of community-acquired pneumonia. But if you have a bad Pseudomonas pneumonia with Cipro susceptibilities, you most certainly can consider that in your treatment of that once you know those susceptibilities and causative pathogens. Moving on to our regimens for severe community-acquired pneumonia. So those are those patients that meet some of those criteria on the previous slide. You can still use your IV beta-lactam plus macrolide. And the guidelines also make recommendations for IV beta-lactam plus anti-streptococcal fluoroquinolones, although in head-to-head trials, those patients did or performed worse when compared to patients on IV beta-lactam plus macrolide therapy. They had higher mortality rates and also more complications secondary to therapy. So IV beta-lactam plus macrolide is preferred. And the only reason the guidelines don't make recommendations for tetracycline-based therapy with an IV beta-lactam in this group is because at the time of the publication of the guidelines, there wasn't strong evidence for that. Not as many trials have been done, although we do have a great deal of retrospective data that supports the use of IV beta-lactam along with doxycycline in this group. So I think it's something you definitely could consider in these patients. And I'll tell you why I think that is because all of these antibiotics have different risk of developing hospital-acquired C. diff. So this data that I've presented to you on the screen was a surveillance study that was done and published in 2014, which looked at patients on the inpatient setting receiving the antibiotics you see listed here below. They have all, pretty much any antibiotic you can think of. I pulled the ones that were pertinent to community-acquired pneumonia because there's a wide range of variability. And the numbers you see at the very bottom of the screen are the odds ratios when compared to a patient not on antimicrobial therapy. Just to briefly walk through this, most of our IV beta-lactams are going to carry some sort of risk for developing C. diff, especially with prolonged exposure. So they had a few studies that looked at penicillin combinations. This included augmentin and unicin. So thinking about unicin as potentially one of your options for community-acquired pneumonia in the inpatient setting. Those patients are roughly 1.5 times more likely to develop C. diff when compared to patients not on that therapy. Our third generation cephalosporins in this study actually were the second leading cause of hospital-acquired C. diff behind clindamycin, causing our patients who were receiving those were 3.2 times more likely to develop C. diff when compared to patients not on antimicrobial therapy. Our macrolides and fluoroquinolones didn't seem to have too much of an effect, although they do increase your odds of developing C. diff to a certain degree. What I really wanted to focus on is our tetracyclines. Actually reducing the risk of C. diff by 23% when compared to placebo. So when thinking about choosing these regimens for community-acquired pneumonia, yes, we want to pick a regimen that's going to cover a lot of our causative pathogens and also be effective and help get or treat our patient. You also have to consider some of the adverse events of these or adverse effects of these medications. And C. diff is probably at the forefront of my mind. So oftentimes, if I can get away with at least recommending a tetracycline in one of these regimens, you could potentially see some benefit there as far as protection from C. diff, especially when used in combination with a third generation cephalosporin. Also, I want to touch on viral pneumonia, as this is a large percent of our patients who come in with community-acquired pneumonia. This is the causative pathogen. It accounts for around 45% of all community-acquired pneumonias during influenza season. I couldn't find any data that was including COVID patients. I would like to see that data because I'm sure this number is actually a little inflated in today's world, especially if you look back at some of the outbreaks we've had with COVID. Also, something to consider is that with influenza positive patients, around 6.1% of them also have a bacterial co-infection. So just because you have a patient with influenza positive pneumonia doesn't mean that they do not need antibiotics, although you could do some further workup to investigate their potential for having a bacterial co-infection. I mean, I found some data for COVID and bacterial co-infection. It's not as heavily associated with co-infection at presentation as influenza. So you see the numbers are roughly half. At 3.5% of patients who present COVID positive will have a bacterial co-infection. This was confirmed with sputum cultures. But a big complication with COVID positive patients actually comes after the resolution of their COVID symptoms. So 14.3% of patients who are hospitalized for COVID and have resolution of symptoms will represent with a secondary bacterial infection. I tried to tease out some of the data to see if that was due to the treatments they received, as some of the treatments that are recommended in COVID management, as you all know, are immunosuppressive in nature. I couldn't tease out that data, so unfortunately that's as far as I could go with that. And also as many as 10% of patients hospitalized with influenza and bacterial pneumonia co-infection die as a result of their infection. So this co-infection carries a pretty large mortality rate. So it's something to consider when you have a patient with a flu positive pneumonia, whether or not those patients need antibiotics on top of that, as you could have some fatal results depending on the decisions you make. So just to summarize what we talked about and also to touch on some other points, the guidelines recommend at least 5 days of therapy for community-acquired pneumonia. I say at least, meaning that if your patient has symptom resolution, they're satting fine on room air, you can stop at 5 days. But if they have lingering symptoms, obviously you can extend that out depending on their clinical course. Anaerobic coverage is a huge talk. I could do a whole 30-minute talk just on aspiration pneumonia and its workup and whether or not you need to cover all aspiration events. Very briefly, the guidelines do not recommend anaerobic coverage and aspiration events unless you have an empyema or some sort of abscess on imaging or you suspect that that's there. There's no need to repeat chest imaging in these patients if they have symptom resolution. And you can also use procalcitonin as a tool to kind of guide the discontinuation of antibiotics, but it should not be used as a tool in community-acquired pneumonia patients to determine whether or not they need antibiotics. There was a study that looked at this, and around 20% of patients that used some of the thresholds of less than 1 is unlikely bacterial and greater than 0.25 is likely bacterial. You miss around 20% of your patients with bacterial pneumonias when using those cutoffs. Therefore, it's not necessarily the best tool by itself to guide the initiation of antibiotics, but it can be useful to discontinue antibiotics after treatment. All righty, so that was a lot. So let's transition to talk about HAP and BAP. I find this a little more entertaining in my opinion. Hopefully you guys do as well. So I think we should start by talking about some definitions. So definitions of HAP and BAP essentially circle around when the symptoms begin. And the key time to remember is 48 hours. So you can have a patient who presents to the hospital, is admitted, and within 24 hours they develop a pneumonia, chest x-ray is positive for pneumonia, they have symptoms. That would not be a hospital-acquired pneumonia because they haven't had enough time to be incubated with a hospital-acquired bug and develop symptoms. So that 48-hour cutoff is very important in both your hospital-acquired pneumonia patients, so that's 48 hours after hospital admission, and your ventilator-associated pneumonia patients, which is 48 hours or more after your endotracheal intubation. Should we get cultures in these patients? The answer is absolutely. How we collect those cultures, the guidelines do lay out some recommendations for that. The thing to take away from this is that your culture should be non-invasive if at all possible. However, sometimes these patients have other indications for BAL, for instance, and getting those cultures is fine as well. So oftentimes you can apply quantitative tests to those. But simply put, if they have no indication other than obtaining samples for getting a BAL, non-invasive sputum cultures are preferred per the 2016 HAP-BAP guidelines. This can be through spontaneous exportation or sputum induction as well. And for your ventilator-associated pneumonia patients, you can get endotracheal aspirate, keeping in mind that a lot of times these are going to be difficult to interpret. Very briefly, your treatment regimens for HAP and BAP are going to center around those bugs we talked about earlier. So those bugs that have high rates of resistance, such as Staph aureus and Pseudomonas, are the two big bugs we're focused on making sure we have adequate coverage for. The guidelines draw a pretty hard line in the sand for double covering Pseudomonas. Once again, that could be another, maybe I'll come back and talk about whether or not we double cover Pseudomonas empirically, as that's something that's been debated for years now. But I won't get into all of that. I'll just briefly lay out what the guidelines recommend. They recommend for ventilator-associated pneumonia and also hospital-acquired pneumonia, covering for MRSA if they have some sort of risk factor for antimicrobial resistance, which you can look at table 2 on the bottom right of this slide. I've cut that straight from the guidelines for you to look at. The big risk factor that's common among all groups is if they've had IV antimicrobial therapy within 90 days. Also, if you have local prevalence of Staph aureus isolates that are methicillin resistant greater than 10 to 20% or just 20% in hospital-acquired pneumonia, I can tell you for our state, we're about 50-50. So I would think most of the health system in our states would kind of meet this qualification for empiric MRSA coverage in hospital-acquired pneumonias based on that. So moving down to double anti-pseudomonal coverage. Essentially, all regimens should contain at least one agent that's active against Pseudomonas, and this should be a beta-lactam such as cefepime or piptazo. However, considering double coverage in patients with a risk factor for antimicrobial resistance, so you can refer to that chart in the bottom right, or if you have greater than 10% of gram-negative isolates that are resistant to an agent being considered for monotherapy. So this can vary obviously from hospital to hospital and also unit to unit. So if you have those unit-specific antibiograms, that would be what would be most important to refer to when treating a patient with this. I can tell you, looking at the statewide antibiogram for cefepime and piptazo susceptibilities to zosyn, we're right at that 10% cutoff. So I would refer you to that if that's something you need to look at. But if your hospital has something that's more specific to your institution, I would refer you to look at that when making some of these considerations. Also, the guidelines briefly mention tracheobronchitis, in which antimicrobial therapy is not recommended routinely. I want to talk a little bit about the most recent reiterations of the IDSA's guidance for some of the management of these multi-drug resistant gram-negative organisms that you'll see in your hospital-acquired and ventilator-associated pneumonias. I think these guidelines are incredible. I refer to them a lot when I'm working up patients. And this will come up in these patients with these nastier hospital-acquired pneumonia cases. Once again, another 30 minutes, I'm gonna have to come back a lot, I guess, because this is something I can present on for quite a while, but I'll just briefly summarize with a quick activity. Hopefully I can get some participation. These are some of the regimens, not the regimens you would always use for some of these MDR gram-negatives that could appear in your hospital-acquired and ventilator-associated pneumonia patients. So I don't know if in the room we want to play this game. I hope this works. As we go through the column on the left here, I've got some lines connecting to some of the agents you could use empirically. So for your ESBL producing Enterobacterales, what would be the treatment of choice generally? These are all generalizations, if I haven't said that enough.
Carbapenem.
Carbapenem, I like it. Oh, it worked, cool. Okay. What about something, if you have a carbapenem-resistant Enterobacterales, what do you think you could use? There's more than one right answer on the slide, but you can. Okay, perfect. I think I drew a line to Taz-Abby because I have told Taz for something else on here. For your difficult to treat Pseudomonas, so these are Pseudomonas infections that are resistant to all of your first-line agents, such as your beta-lactams, carbapenems, and also your fluoroquinolones. Okay, I like it. 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 AMP-C producing organisms, clinically relevant AMP-C producing organisms. So you have Citrobacter frundi, or you have E. cloacae, causing a hospital-acquired pneumonia. I would say cefepime for sure. It's not only a poor substrate for AMP-C, but it's a poor inducer as well. For your carbapenem-resistant Acinetobacter baumannii, if you had one of those, a potential treatment regimen could include. Nice, nice. Say it with your chest, man. So it's strictly for that sulbactam component being active against Acinetobacter. And then you've only got one option left for Acinetrophomonas infections. A treatment regimen can include Bactrim. You can also use Levaquin, Ceftaz, and some combinations of such as well. And some of our tetracyclines also play a role in the management of Acinetrophomonas infections. But just keep this in mind when you have hospital-acquired pneumonia due to one of these nasty gram-negatives. I would refer you not only to the pneumonia guidelines, but also to the guidelines specific for the management of those organisms. All righty. So how long do we treat these hospital-acquired and ventilator-associated pneumonias for? The answer is at least 7 days, following a seminal principle put out in the community-acquired pneumonia guidelines. If your patient's not clinically improving or is not kind of where we want them to be, you can extend that out from 7 days. Those cultures you get can be vital in providing routes for de-escalation, and you should de-escalate your antimicrobials based on the results of the cultures you collected. And similar to community-acquired pneumonia, you can use procalcitonin to guide the discontinuation of your antimicrobials. All right, just to summarize all of that, so community-acquired pneumonia versus hospital-acquired pneumonia, some of the differences and similarities. Community-acquired pneumonia is going to be onset in the community or within 48 hours of hospital admission. So as long as you haven't been in the hospital for 2 days, that could still be considered a community-acquired pneumonia. Hospital-acquired and ventilator-associated pneumonias, as I talked about, that 48-hour time period is very vital. The pathogens kind of vary pretty significantly between the two conditions. With our pathogens we worry about in community-acquired pneumonia being strep pneumo, Haemophilus, and also our atypicals, with rising rates of Staph aureus in the community as well, as I touched on. Compare that to our hospital-acquired cases where we have more of our resistant organisms at play, such as Staph aureus, Pseudomonas, and some other gram-negative enterics. Durations of therapy are 5 for CAP and 7 for HAP. And then some of the similarities between the two, procalcitonin may be useful to guide the discontinuation of your antimicrobials, though it should not be the sole tool used to guide the initiation of antimicrobial therapy. And some pearls to always remember, push for culture collection in both of these scenarios. Sputum cultures can be extremely helpful in guiding antimicrobial therapy and avoiding antimicrobials in some cases. And we saw some of the detrimental effects in this presentation of antimicrobial therapy, mainly being C. diff. MRSA nasal swab can be extremely helpful in hospital-acquired pneumonia cases to quickly rule out a Staph aureus pneumonia. The negative predictive value of those, just for reference, and multiple studies have been greater than 95%. So you can safely rule out a patient having a Staph aureus pneumonia within a few hours if your hospital is ever able to perform this rapid PCR test. And then urinary antigens as well for some of those community-acquired infections, mostly our pneumococcal infections and also Legionella. Which brings me to the last thing I want to talk about today. I want to briefly look at the South Carolina specific guidelines that we have regarding the treatment of urinary tract infections. As you remember from the beginning of my slideshow, we have guidelines for both the inpatient and outpatient management of urinary tract infections. I'm going to be focusing on the inpatient management of urinary tract infections. So just to lay out the definitions of urinary tract infections and some of the classifications, this may seem simple, but it's pretty important when working up your patient, as this oftentimes defines what agents we can use and for how long we need to treat for. Cystitis is going to be one of those bladder infections or lower urinary tract infections, which can further be divided into uncomplicated and complicated cystitis. Uncomplicated cystitis is essentially patients who are females of childbearing age with no urologic abnormalities. Complicated is going to be patients who have multiple UTIs within the past year, urologic abnormalities, including stones, males with cystitis, and also patients with indwelling catheters. And then pyelonephritis or upper urinary tract infection is going to be an inflammation of the kidneys, so this is going to be kidney infection. The symptomology kind of differs between the two of these. So these are some things that the guidelines for our state mention that you can use to kind of differentiate between the two of them. Cystitis, you're going to see more of a dysuria picture, although you can have that with pyelonephritis as well. Some new or increased frequency or urgency, suprapubic tenderness. So the location of where the pain is very important for differentiating these two symptoms or these two clinical conditions. You can have pyuria on urinalysis, but we'll talk about urinalysis in 1 second. And usually these patients are not going to have systemic symptoms such as a fever, so they'll usually be afebrile. Compare that to our pyelonephritis patients. They're usually going to present with unilateral back or flank pain, which is associated with the anatomical location of the kidney, costovertebral angle tenderness. If you have imaging, such as an ultrasound of the kidneys, you could have radiologic evidence of kidney involvement. And these patients are usually going to have more systemic symptoms of an infection, including a fever. Some diagnostics that are extremely important in the management of urinary tract infections include urinalysis and urine culture. which should be obtained in all patients we're going to be managing on the inpatient side for urinary tract infection, and if possible, should be obtained prior to starting antibiotics in patients. Additionally, patients who have indwelling catheters that have been placed for more than 2 weeks from the onset of symptoms should have that catheter removed and replaced prior to obtaining a urinalysis in urine culture, as that can be colonized with pathogens that aren't indicative of an infection. And you do not need to get follow-up cultures to assess treatment efficacy for cystitis and pyelonephritis to document cure. These are just some things to keep in mind. So let's talk a little bit about asymptomatic bacteriuria. So treating asymptomatic UTIs is strongly discouraged in most populations because antibiotics may lead to harmful effects for patients. We already talked about one of those, but if anybody in the, I guess I can't see the chat unfortunately at the moment, but if anybody wants to shout out in here some complications or harmful effects of antibiotics that you could see. We talked about one today already. C. diff is a big one. So if you have a patient with an asymptomatic urinary tract infection, you're giving them antibiotics for essentially no reason. You can potentially have a patient develop C. diff. Some other things you could see is induction of antimicrobial resistance, which is huge, especially with patients who have multiple exposures to antimicrobials. And then just some drug-specific adverse drug events as well. Now, I say most patients should not be treated for asymptomatic bacteria. There are a few exceptions to that. Does anybody know some of those exceptions where you may want to treat someone with an asymptomatic pregnant women's a big one? That's the one that comes to my mind first as well. And there's one other large patient population that I think of as well, where you would consider this.
Any obstruction or any abnormalities?
I would say those patients would usually endorse symptoms, but in light of symptoms, I don't think that patient population would be. Oh, we got something to chat. Oh, Lord have mercy. Urologic procedures, that's what I was looking for. Thank you. Sorry, my vision's, I need to go get new glasses, but yes, that's what I was looking for. So patients who are going to have some sort of instrumentation of their urinary tract. This can be in the case of like a TURP or other urologic procedures. Perfect. Just to briefly touch on the microbiology of urinary tract infections. So these are charts of complicated and uncomplicated urinary tract infections. You can see the number one player, regardless, is going to be E. coli, accounting for roughly 3/4 of our urinary tract infections on the inpatient side. However, when looking at uncomplicated versus complicated urinary tract infections, there are some differences in some of the other pathogens, mainly being in our uncomplicated patients. Second leading cause of uncomplicated urinary tract infections is Staphylococcus saprophyticus, which is normal flora in the vaginal canal but can become displaced. So this is actually one of the leading causes of urinary tract infections in sexually active women of childbearing age. Other gram negatives can be at play with these urinary tract infections, such as Kleb pneumo. And then we do have to worry about certain gram positives other than Staphylococcus saprophyticus, such as Enterococcus and group B strep. When we're talking about our complicated urinary tract infections, we do become worried about some of our other organisms, such as our yeast, Candida species, and also Staph aureus. Keeping in mind that oftentimes if you do catch a Staph aureus on a urinary culture, that could be indicative of a bloodstream infection or some other infectious process that usually warrants further workup. And just to kind of walk you through, so I snipped these straight out of the guidelines. They're very reader-friendly in my opinion and easy to follow. So I mentioned that the classification and the anatomical location of the urinary tract infection is important because it guides treatment. And this is a good illustration of just that. So you can look and see our uncomplicated cystitis patients here. Treatment options include macrobid for 5 days, as long as their renal function can tolerate it. A one-time dose of fosfomycin, keeping in mind that some of the data comparing nitrofurantoin to fosfomycin head-to-head has shown that macrobid does perform better in clinical and microbiological eradication of urinary tract infections. And another option is Bactrim for 3 days, a double-strength tablet every 12 hours for 3 days. With the important footnote here to avoid it if they have used Bactrim prior or if they've had a urine culture with a Bactrim-resistant bacteria within 12 months. In those complicated cystitis patients, which we've already talked about what would define someone as complicated cystitis, some options include an extended course of macrobid up to 7 days, or an extended course of Bactrim for 7 days. If IV antibiotics are indicated in these patients, since they are hospitalized, you can use some of the same options as for pyelonephritis, which I've laid out here. If a patient has no risk factors for drug-resistant bacteria, then our go-to in the inpatient setting for pyelonephritis will be ceftriaxone. If they do have risk factors for Pseudomonas or any other ESBL-producing bacteria, which the guidelines lay out beautifully here, such as severely immunocompromised host, being hospitalized for more than 5 days, some sort of beta-lactam use within 90 days, or colonization with Pseudomonas or an ESBL-producing organism in the past 12 months. Your go-to choices are cefepime and ertapenem, respectively. You're going to treat these patients for up to 1 to 2 weeks, depending on clinical course and also the presence of other infectious processes, such as a concurrent bloodstream infection secondary to the pyelonephritis. And then keeping in mind that if these patients improve and are otherwise ready for discharge, we do have some oral de-escalation options, mainly in the form of Bactrim or our fluoroquinolones, being levofloxacin and ciprofloxacin. So just some pearls on urinary tract infections. We classify these patients based on anatomic location of infection and also the complexity of their infection. If at all possible, diagnostics should be ideally collected prior to starting antimicrobial therapy to ensure a good collection. Asymptomatic bacteriuria should not be treated in most circumstances. We talked about some exceptions to that and why, some of the risk of treating those patients. And the pathogens can vary depending on the complexity, although across all groups, E. coli is by far the most common pathogen. And with that, I am done for today. Thank you all for giving me the opportunity to speak today. I really appreciate it. If anybody has any questions in the room or in the chat, I'd be happy to answer those.
That was fabulous. For everyone kind of online, I'm Sarah Battle, one of the ID physicians in the Midlands. I was kind of taking notes